locations, outpatient hospitals, we're coding same-day surgery, so we know we're coding ICD-10 diagnosis, Cpt procedure, right? And then our pre-op diagnosis is a post-operative wound infection, 1 week status post-cesarean section, patient just delivered, and then considered OB care condition. Post-op diagnosis is the same. So when we're reading op reports, many times the post-op diagnosis is the same as the pre-op diagnosis, but not always. And why this is important is the pre-op diagnosis is what they think is going on. The post-op diagnosis is what, after surgery, they confirm, they know is going on. So you never want to code the pre-op. You always want to code the post-op. Okay? And again, many times they're the same, so it doesn't really matter. But if they're separate and they're not the same, make sure you're using the post-op diagnosis, because that's definitive. They already went in and looked, and they know. Where the pre-op, they're just thinking they know. Right? Does that make sense? So our procedure performed, we're doing a wide wound exploration with excision of necrotic skin and subcutaneous tissue. We're debriding some abscesses. The frozen section obtained intraoperatively revealed a mixed picture of granulation tissue, inflammation, and necrotic tissue. The necrosis did not extend to the end of the resection. The edge of the resection was viable. So this is a post-operative wound, incision, and drainage of the skin. Okay, so the procedure performed statement usually tells you what they're going to do. And the procedure itself, you want to make sure verifies that that's what they did, okay? So now let's read the actual procedure. After good general endotracheal anesthesia, the patient was prepped and draped in the usual sterile fashion. The entire previous C-section incision was opened from side to side, and the necrotic skin edges were trimmed away. Specifically, there was a 6 by 6 centimeter central portion of grossly necrotic tissue that was debrided away. The subcutaneous tissue beneath this was clearly necrotic, and this was also debrided away. Skin edges on both sides were debrided away until there was bleeding. Viable tissue noted. The incision was extended laterally as there was infection that had tracked laterally on both sides, and abscess cavities were uncovered here. All clearly necrotic tissue was debrided away. Hemostasis was obtained with electrocautery. The wound was irrigated and then packed with some damp Kerlix. Plans were made to look at the wound again tomorrow in the operating room and debride away any other marginal tissue. Pathology report shows granulation tissue, inflammation, and necrotic tissue. Okay, so as we're coding procedures, remember we have what are called surgical packages, right? Surgery codes are bundled with everything that is used to do that or complete that surgery is in the code, right? So we're not coding for separate things. It's all included. And what I mean by that is, let's take the first sentence. After good general endotracheal anesthesia, the patient was prepped and draped in the usual sterile fashion. Obviously, our patient is given anesthesia, right? We're not going to take them out back in the alley and just cut them open. So the anesthesia is something that the surgery coder is not coding. The surgeon did not provide that anesthesia. As we learned when we coded anesthesia codes, the anesthesiologist is the one that codes for the anesthesia, right? So the surgery coder or the hospital same-day surgery coder is not coding for that anesthesia. It's inherent in our surgery that our patient was given anesthesia. And then let's go to sentence 2. The entire previous C-section incision was opened, and from side to side, the necrotic skin edges were trimmed away. Specifically, there was a 6 by 6 centimeter central portion of grossly necrotic tissue that was debrided away. The subcutaneous tissue beneath this was clearly necrotic, and this was also debrided away. And then skin edges on both sides were debrided away until there was bleeding. Viable tissue noted. The incision was extended laterally as there was infection that had tracked laterally on both sides, and abscess cavities were uncovered here, all clearly necrotic tissue was debrided away. So that's the whole incision and drainage that we said we were doing up here under procedure performed. That's what they did, right? We made an incision into the previous incision, and they debrided and drained all the necrotic, all the dead tissue away. And then if we go to where we left off, hemostasis was obtained with electrocautery, the wound was irrigated, and then packed with some damp Kerlix. So that's all part of the procedure as well. Obviously, once they clean out the patient, sorry, I have something in my throat, they're going to make sure that the patient's wound or area is irrigated, and then they're going to put some Kerlix in there to absorb whatever is draining off, right? So we're not coding those separate. That's part of the incision and drainage. And then plans were made to look at the wound again tomorrow in the operating room and debride away any other marginal tissue. Okay, we can't code that because it hasn't been done. Plans were made to look at this. So that's something tomorrow, if there's a same-day surgery, again, like let's say today this was done on 4-1, tomorrow 4-2, they're doing this other one, then you would code it again when it's done. But you can't code something if it wasn't done yet. So we're not coding that. And the pathology report just confirms, right, what the tissue was. So you use that as a diagnostic statement if needed, but it just confirms that it's just an infection. So it confirms the diagnosis. So in this case, we're coding the complication of our C-section wound, and then we're coding the incision and drainage, okay? So let's first do our Cpt code, and we're going to code the incision and drainage. So I'm on page 975 in my CBT index under incision and drainage. And then you have to ask yourself, incision and drainage of what? What did we incise and drain? We incised and drained a wound, right? A C-section wound. So let's go to W, to wound. And hopefully you guys are on page 976. And we have one code, right, under wound infection skin, 10180. So let's flip to that, 10180. So I'm on page 79. And if we look at the description under 10180, it's incision and drainage complex post-operative wound infection. Okay, so that's pretty much exactly what we did. And then the last thing you always want to do with CPT is ask yourself if a modifier is needed. Not every case needs a modifier. Many cases don't have modifiers, but some do. And this case is actually one that has a modifier. So if we open up the inside cover of our CPT manual, that's where all the modifiers are. Remember that there's two columns. The column on the left is the physician modifier. So if you're working for a physician, if you're coding for the actual physician office, those are your modifiers. And the column on the right are the HCPCS or the hospital modifiers, under the modifiers approved for hospital outpatient use. So in this case, what modifier do you guys think we would use? Anyone have any ideas? I'll give you a hint. It's because it's post-op, right? She's coming in for a complication from a previous surgery, right? She had a C-section, and she's coming back in for a post-op complication. So that's the hint of the modifier we need. So very close. 58, the stage procedure is if you're coming in for something that's going to take more than one procedure. Like a stage procedure, for example, if a patient, let's say our patient has breast cancer, and we're going to do a radical mastectomy where we're taking out, the entire breast, mammillary glands, axillary nodes, but we can't put in the implants, the breast implants right then because the patient has to heal. So it's a planned procedure for her to come back and get the implants at a later time. That's an example of 58. Yes, 78. That's exactly the modifier we want. So 78 is an unplanned return to the OR for the same kind of procedure, right? Perfect. So our procedure is the 10180 with modifier 78. And then our diagnosis is going to be this post-op wound infection, right? So remember, anytime you're coding anything that happened post-op, our main term is going to be complication. So in your ICD-10-CM index, which is in the front, remember we're going to go to complication, and then complication of what? What was complicated? It was a C-section wound. So under complication, let's see if we can find C-section. And C-section, really the real term is cesarean, right? So make sure to look for cesarean. So on page 60, I see complication, and then almost at the bottom is cesarean delivery wound, and then indented we have disruption, hematoma, or infection following delivery. And that's the one we want, is infection following delivery, and it gives us code 086.00. So now let's flip to that, 086.00. I'm on page 877 in the tabular list, and if we look at 086.00, it says infection of obstetrical surgical wound. Unspecified. Well, we don't want unspecified because we know what ours was, right? So if we look right through that, infection of obstetrical surgical wound, superficial incisional site, and it tells us even more. Subcutaneous abscess following an obstetrical procedure, or stitch abscess following an obstetrical procedure. And that's the one we want, right? Because we know it was in the subcutaneous tissue. That's what was debrided away. If we go down one more, the 086.02 is infection of obstetrical surgical wound deep, and it tells us deep is intramuscular or subfacial. So we did not go that deep. So we want to make sure we get the superficial incisional site, which is the code 086.01. Okay, so our codes for this one, our diagnosis is the 086.01, and our procedure is the 10180 modifier 78.